Hello, everyone. Welcome to PM Rounds with Chris, a podcast exploring the wonderful world of medicine and healthcare. My name is Chris, your host, a current internal medicine resident, and my goal is simple: to make complex medical topics both educational and entertaining. And today we are going over something very exciting, the story of sepsis. So we're going to talk about some history, controversies, and how we arrived at our current understanding and definitions of sepsis. Now, before we get to the fun stuff, a quick disclaimer.
This podcast is an independent production. The views and opinions expressed here are my own and those of my guests, and do not represent the views of my residency program, any hospital, affiliated institutions, or employers. This content is intended for educational and entertainment purposes only, and should not be considered medical advice. Clinical decisions should always be made based on the individual patient's circumstances, institutional protocols, and consultation with appropriate medical professionals.
In other words, I don't know anything, and please don't listen to anything I say. All right, now back to the fun stuff. So sepsis. So the word sepsis is derived from the Greek word for decomposition or decay or rot. And its first documented use was about 2,700 years ago by Homer in the book The Iliad. And for those of you who have read it or have perhaps seen the movie Troy, after Achilles killed Hector and dragged his body behind a chariot, apparently for 12 days, the gods intervened basically to prevent decay because they looked upon Hector favorably. And the god Apollo apparently wrapped Hector's body in like a golden aegis, which was some sort of divine shield or breastplate, so that his body would not be damaged as it was being dragged. And this also ensured that it would not become, torn or rotted despite the repeated desecration by Achilles. So Homer used this term to highlight a lack of rot or decomposition that he would identify as being akin to sepsis, essentially. Now, in terms of medical use, the medical use of the word sepsis was really first described by Hippocrates, who many consider to be the father of medicine, in around the 400s BC, where he viewed sepsis as essentially a dangerous biological decay, or I think the translation was putrefaction, that was occurring within the body during this illness state. Interestingly, another historical physician, this guy was named Galen. He lived from about 129 to 199 AD, so he was a Roman physician. He had a fairly advanced understanding of sepsis. So he was a physician, surgeon, philosopher. He was born in the ancient city of Pergamon, or Pergamon, I'm not sure how it's pronounced. This is in present-day Turkey. And Galen actually traveled extensively. He was the son of like a wealthy architect, so he had a lot of money to basically afford for his education and his own travels. And I think what they did for fun back then was they got educated for fun, because when you had a lot of money and you didn't have to work, that's kind of just what you did. And so he traveled a lot, and he educated himself in a lot of different medical theories and discoveries before eventually landing in Rome. And this was where he was eventually given the position of being a personal physician to some of the emperors there. And in his writings, he suggested that sepsis was the result of what he described as invisible creatures or miasma, like putrid fumes, that were causing internal decay. So all things considered, and this was, back in, 129 through 199 AD, that's when he lived. So very early on, he had a fairly advanced understanding of sepsis, and especially with this reference to invisible creatures or putrid fumes that kind of cause people to become sick and almost rot from the inside out. And of course, you can't discuss medical history without mentioning Dr. Osler, who many consider to be the father of modern medicine. And in the 1800s, he made the interesting note that, except on a few occasions, the patient, who is septic, appears to die from the body's response to the infection rather than of the infection. And this communicated what was a very advanced understanding, especially at the time in the late 1800s, of sepsis. And, what he's referencing here is the body's immune system or an immune system hyper-response or hyperactivation in response to infection that's causing many of the severe complications that we see with sepsis. So already, even at this point, we had an understanding that sepsis was an inflammatory reaction by the body, causing some sort of, in the ancients described it as a decay or rot, in reaction to, some sort of stimulus. And then, as we get into the late 1800s and early 1900s, when we basically figure out germ theory, right? When germ theory was conceived, we began to realize that sepsis is basically a response to that. It's a form of recognition that sepsis originated from pathologic microorganisms, right? And the first modern definition of this was attempted in 1914 by a doctor called Hugo Schott-Muller, who wrote, and this is a direct quote, sepsis is present if a focus has developed from which pathogenic bacteria constantly or periodically invade the bloodstream in such a way that this causes a subjective and objective symptoms. So he had a pretty good understanding too, and this was back in 1914. And subsequently, over the course of the 20th century, numerous experimental and clinical trials were able to demonstrate the importance of the host immune response in terms of the manifestations of sepsis. So that's kind of what Osler was talking about. However, due to the heterogeneity of the disease process, it posed serious difficulties in recognizing, treating, and studying sepsis. And most importantly, going forward, scientists wanted to create specific criteria, especially when they start doing clinical trials and publishing, so that they could have good inclusion criteria to determine, okay, how do we say for sure whether one person is septic and one person is not? So they were looking for very specific inclusion criteria. That way they could start, kind of putting patients into a certain box or category so that they can then go on to do clinical trials and investigate the effect of different therapies in the process of sepsis. So this brings us to 1991. So basically, all the big players at that time wanted to get together and convene and decide on a universal definition for sepsis. So this was the International Consensus Conference. It was convened by the American College of Chest Physicians and the Society of Critical Care Medicine. And so they just had two organizations and mainly 8 people that kind of chaired the committee. All 8 of them were critical care trained in some way or another. 4 of them were specifically pulmonary and critical care trained, and one of them was actually kind of more surgical critical care trained. And they ultimately decided on the SIRS criteria, the Systemic Inflammatory Response Syndrome, basically is what SIRS stands for. And the reason why they landed on this criteria, and for those of you who don't know, the SIRS criteria are basically fever, tachypnea, tachycardia, and leukocytosis or leukopenia. So it's based on temperature, respiratory rate, heart rate, and white count. So those 4 things. And they essentially decided that if you have at least 2 of those 4 things, plus a suspected source of infection or confirmed infection, that this was going to be the definition of sepsis. And the reason why they kind of decided on this specific criteria was there was a lot of optimism in the 1980s and 90s that modulating inflammation with immune modulators, like they were discovering all these different cytokines and things like tumor necrosis factor and different exotoxins. So there was a lot of excitement at the time that if you have therapies that can target these specific cytokines, and knowing that these different cytokines are driving the inflammatory cascade that's propagating sepsis, that if you're able to target these things, that you can basically stop sepsis. There's a lot of optimism at that time for doing that. So basically addressing sepsis from the inflammation standpoint. So they wanted a score that could basically reflect that, kind of reflect total body inflammation, if that makes sense. And that's how they decided on SIRS. So, the fevers, the tachypnea, tachycardia, leukocytosis, elevated white count, so that's kind of how they landed on this. Furthermore, they added in additional definitions. So they said severe sepsis is going to be if you have sepsis plus end organ dysfunction. So if you have infection, SIRS criteria, 2 out of 4 at least, plus end organ dysfunction or some sort of damage, that's going to be severe sepsis. And then septic shock if you are septic and you have low blood pressure, hypotension, despite adequate fluid resuscitation. So SIRS was really popular for a while. However, I want to kind of say that this criteria really wasn't great. All right. And it's interesting because, we see SIRS kind of being used regularly on the wards today. I still hear, residents, attendings, medical students, a lot of people kind of referring to SIRS. And I do think it has its utility. But, I want to kind of identify that this criteria in terms of trying to identify sepsis is really not that good. Again, this is more of an inflammation score than a septic score. And if you look at the data, when you use SIRS, despite the fact that it was deliberately designed to be fairly sensitive for sepsis, a lot of non-septic patients are actually missed, right? Some studies and some cohorts of patients with sepsis, up to 12.5% of these patients who are septic do not even meet SIRS criteria anyway to begin with, right? So so the SIRS basically is not nearly as sensitive as maybe everyone thought. So now fast forward, let's go about 10 years later. So we were in 1991, 1992. This is when we have the Sepsis 1 definition. So the first conference, we're going to call that Sepsis 1. Fast forward to 2001, we have Sepsis 2. So this is about 10 years later. The Sepsis 2 conference. This is the second International Sepsis Consensus Conference. So they came together, and this time it involved many different groups. So before, we just had the chest physicians and basically the critical care society, just those two people. Now we have several different groups, okay, in addition to the chest physicians, ACCP, and the SCCM. Instead of eight main people kind of putting this together, they had almost 30. Okay, there was about 27 on the final paper, I believe. And they were all listed as the primary participants in the final report. And some of these bodies that were represented were the Society of Critical Care Medicine. The European Society of Intensive Care Medicine also came in, the ESICM. American College of Chest Physicians came back too, the ACCP. American Thoracic Society, the ATS, they weighed in. The Surgical Infection Society, the SIS. So they represented all sorts of different kind of specialists across several different disciplines, including, pulmonary, critical care, surgery, ID, pediatrics, medicine, emergency medicine. So it was a lot bigger of a group this time. And ultimately, they did a lot of talking, but they kind of walked away from Sepsis 2, the Sepsis 2 conference, with the same definition. Okay, they kept the definition of sepsis, which was SIRS criteria plus a source. However, they also wanted to add on what was essentially a menu, almost like a menu of other items that could be selected a la carte that are associated with sepsis, right? So they came out with this big table of different things. So, just to go through some of these other signs and symptoms of sepsis. For general symptoms, rigors and fevers, tachypnea, positive fluid balance, anasarca, edema. They added in hematologic or inflammatory markers, so CRP, procalcitonin, interleukin 6, leukocytosis, right? Hemodynamic alterations, so hypotension, tachycardia, increased cardiac output for patients where it was measurable based on, SWAN labs that you get through the SWAN catheter and all that good stuff. Low SVR, altered skin perfusion, so cool, mottled extremities, petechiae, decreased urine output, elevated lactate, so they added in some more lab values, and then signs of organ dysfunction. Hypoxia, altered mental status, rising creatinine, poor renal function, hyperglycemia, thrombocytopenia, altered gut motility, intolerance to feeding, altered liver tests, you can go on and on. So they added in all these different kind of items here. And essentially, you can choose a la carte, basically off this menu of items, to try to figure out if your patient has sepsis. Now, the problem here is that they gave all of these different, they gave this huge table, overwhelming table of different signs and symptoms, but they didn't actually propose a criteria. They gave a list of possible signs, and they wanted to, the reason why they didn't propose like a certain criteria was they wanted to protect against exclusion of patients who are potentially septic, and then, maybe if they're not meeting a certain criteria, they'd be excluded from research, and then this would, hurt the patients, it would hurt the research, it would lock clinicians into a bad definition, so that's all fair. These are all good points. But the problem is just adding in all these other things made identifying sepsis like the Wild West, and it just fed the vagueness and the confusion for years to come after 2001, 2002, right? And then what ended up happening was, because this table was like so much less digestible than the SIRS criteria, because, going back to SIRS, it was really easy. Okay, all you needed was like a CBC, identify some leukocytosis, take that respiratory rate, look at the tachypnea, is the respiratory rate greater than 22? Do they have a fever? So just measure the temperature with a thermometer. If it's greater than 38, boom, you're there. The leukocytosis, is your white count greater than 12 or less than 4 for leukopenia? The tachycardia, are you greater than 90 in your heart rate? If you just have 2 of those and then you think you have an infection, boom, you're done. Sepsis, right? Very easy. And then you introduce this big table. It's overwhelming. No one wanted to use it, so everyone just stuck with SIRS. And because everyone stuck with SIRS, basically every patient with an infection, because as you know, it doesn't take much just to get a fever and a white count, right? Any sick person can basically get that. Sepsis basically became the same thing as having an infection, right? And then, of course, after people started utilizing SIRS more to diagnose sepsis, the reported incidence of sepsis increased dramatically, of course. And this was not only because of the definition, but it also increased because of, various pressures such as hospital financial incentives, right? And this part is actually very interesting. So why was identifying sepsis financially profitable for hospitals? Well, first of all, hospitals want what's best for the patients, right? I don't think there's any doubt about that. I think hospitals mostly have good hearts, right? And I think better patient outcomes and better patient care will undoubtedly translate to basically better finances for the hospital, right? So I think it's a win-win in most cases, and there were studies showing that improved outcomes with implementation of certain, let's say, sepsis bundles, and we'll kind of get into what those are later. That if you're able to recognize sepsis early and implement these treatment bundles, that the patients will do better. And of course, hospitals want what's best for the patients, and they'll make more money when the outcomes are better. And it also allows for the avoidance of certain tragedies that could be really bad for hospital reputations, right? There was a very well-published tragedy. I think it was back in 2011, 2012, something around then. There was, unfortunately, a 12-year-old boy who apparently had a minor playground skate, had like a minor scrape or some sort of like a minor injury from basically just playing on a playground. And then he went to the hospital, some hospital in New York, and unfortunately he developed fatal sepsis from that very mild wound, and the boy ultimately passed away. And it was a very tragic case, very sad, and of course there was like public outrage in response to this. And as a result, New York became the first state to basically mandate sepsis protocols. This was called Rory's Regulations. Back in 2013. So they basically mandated all hospitals in New York to have their own protocols for sepsis to prevent tragedies like this from happening. Now into the more financial stuff. So reimbursement formulas, right? Reimbursement formulas are making hospitals more diligent about coding for sepsis and for acute organ dysfunction. Hospitals began training clinicians to document sepsis and make sure to note the difference between documenting sepsis or severe sepsis, specifically because these diagnoses move patients into higher paying diagnosis related groups or DRGs. Because based on the Sepsis 2, the 2001 updates, they provided a much longer list of clinical signs, like for instance hyperglycemia or altered mental status. It became easier for hospitals to document sepsis for patients who would previously just be labeled with, let's say, pneumonia or a UTI, right? If you look for this menu of other items and you pick from them and you're able to upgrade the diagnostic criteria to like a more severe rating like severe sepsis, you can use a higher billing code, which means more money for the same patient encounter. So this was big. And, just to give you an example of how this is, if you bill for like a simple pneumonia without complications, that leads to a certain number value. I think, if you look up the DRGs for this, about $6,800. Whereas if you bill for simple pneumonia with some sort of major complex complication, you can bill closer to $11,000. Right, and this is all like public data that I'm using. This is not inside info. You can get this from like the Medicare websites, basically, And then if you, for instance, if you bill for severe sepsis, right, septicemia or severe sepsis with an MCC, a major complex complication, your billing goes from the previous 6 to 11,000 to 14 to 22,000, right? And then if the patient requires mechanical ventilation, that payment could jump to well over $40,000, right? So it kind of goes to show that for the same patient encounter, having that that initial labeling diagnosis can result in reimbursement differences. And sometimes these differences can be as much as an increase of like $6,000 in that example of billing for pneumonia without severe complications to like septicemia or severe sepsis, right? And while sepsis stays are more expensive for hospitals to treat because there's a lot more kind of complex care involved, the margin for profit is still higher, even because of the fact that the profit. So what the hospital is able to bill for is still higher than what it costs to care for the patients, right? And auditors, interestingly, actually have found that many hospitals have continued using the 2001 Sepsis 2 definitions long after the 2016 Sepsis 3 definitions were released. And this because in the 2001 definitions, not only was it easier to stick with the definitions that you kind of had implemented in your hospital previously, right? And all the physicians and all the coders were used to kind of billing for this, but the 2001 versions allowed for a sepsis diagnosis based on like softer criteria, like an elevated heart rate or fever, right? And it made it easier to trigger a higher paying diagnosis code. So it's very interesting to see kind of how the financial aspects of things can also influence the way we define certain medical terms like sepsis, right? So let's fast forward to what happened around the same time as the formulation of the Sepsis 2 definitions, right? So we're kind of going back to 2001, 2002. That's when the Sepsis 2 conference and those definitions came out. In 2002, the Surviving Sepsis campaign was launched. This campaign was founded as a joint collaboration between three major professional organizations, right? The Society of Critical Care Medicine, the SCCM, European Society of Intensive Care Medicine, the ESICM, and the International Sepsis Forum, the ISF. And this Surviving Sepsis campaign was launched primarily to address the high mortality rates and inconsistent care associated with sepsis worldwide. Right, sepsis, it was extremely common. It was not the number one leading cause of death, but it was a leading cause of mortality. Notably, there was a lot of poor or delayed recognition, right? They wanted to reframe sepsis as a medical emergency, something that, could not be waited on, something that has to be recognized and treated right away, which is perfectly fair. And of course, there was kind of confusing clinical guidance. There wasn't a good definition of sepsis, and there wasn't a good standard of care. And this was an expensive, as we discussed the Medicare cost and everything, and the reimbursement. This is an expensive disease to treat, right? An economic burden that costs billions of dollars annually, right? So they came up with something called the Barcelona Declaration in October of 2002. The Barcelona Declaration was basically like a promise to the world that they wanted to reduce sepsis mortality by 25% within 5 years. So a very lofty goal. And this concept was led by doctors like Dr. Mitchell Levy, Dr. Phil Dellinger, and Dr. Graham Ramsey, who was then at the time the president of the European Society of Intensive Care Medicine, I believe. And they presented it. The reason why it was called the Barcelona Declaration was because they presented this Surviving Sepsis kind of campaign idea to a bunch of intensivists that were at the 15th Annual Congress of the ESICM in Barcelona, Spain. So that's why it was called the Barcelona Declaration. They did it in Barcelona, Spain. Now, part of this, interestingly, was inspired by what was called the Rivers study. So this was a study done by a very prominent physician, a very smart physician named Dr. Emmanuel Rivers, right? And this famous Rivers study came out around the same time as Sepsis 2 was coming out. So it was in the early 2000s. And essentially what they showed was with their specific diagnosis method and treatment bundle for sepsis, that they were able to get a mortality reduction of 16%, which translated to a number needed to treat of just 6 patients to save a life, essentially, with their protocol and methodology, right? And then, as part of their protocol, it included early invasive access, so like putting in an A line, central line access, giving oxygen, giving fluids empirically, monitoring urine output and certain transfusion thresholds in order to give blood, placing patients on certain pressors like dobutamine, drawing cultures, giving antibiotics early, trending lactate and measuring lactate. So they did all of these different kind of interventions, and most importantly, they had a structured and systematic approach to identifying and treating sepsis, right? And then this was called the EGDT, the End Goal Directed Therapy protocol, and this was adopted as basically the backbone for the treatment recommendations in the Surviving Sepsis campaign. Now, unfortunately, this campaign faced a lot of controversy. And one of the reasons was, of course, not everyone was 100% convinced of the power of the study, essentially, of the river study. That was kind of the backbone of this. But besides that point, the fact that it had a lot of big pharma or kind of pharmaceutical support, specifically the company Eli Lilly, provided over 90% of the initial almost $1 million of the, so 90% of that, of the initial grants used in the campaign's first medical recommendations. And many thought that the campaign was essentially going to be like a marketing ploy for Eli Lilly's kind of new sepsis drug, which was called Xigris, Xigris, which was essentially recombinant human activated protein C. The theory here was that patients with severe sepsis, studies had shown that they had low levels of endogenous activated protein C. And activated protein C in the body is a natural anticoagulant that has anti-inflammatory properties as well. So if you have sepsis where you typically have excess clotting, especially in the microcirculation, excess inflammation and microvascular thrombosis, and if APC, activated protein C, can combat the clotting, can downregulate the inflammatory cytokines, that it will help, which was reasonable. But the thing was, this recombinant activated protein C, Xigris, it was expensive. It was costing roughly $6,000 to $8,000 per 4-day treatment course for each patient. And it was FDA approved around 2001, so right before they started doing the Surviving Sepsis kind of campaign. And this was based on a single trial, a single multi-center trial called the Prowess clinical trial, which showed a reduction in the 28-day mortality in high-risk severe sepsis patients. And it ultimately had like a split, I think it was 10-10 advisory committee vote, in terms of kind of its final voting for its approval. So Xigris was actually implemented into guidelines such as the 2004 and 2008 Surviving Sepsis campaign recommendations, right? So it was actually formally implemented into the recommendations, and it was listed as a recommended therapy for certain patients with severe sepsis and high risk of mortality. However, results from a subsequent trial, this was the Prowess shock trial, that was done later, closer to 2010, 2011. This was a large follow-up study that showed no statistically significant decrease in mortality for Xigris compared to the placebo. And of course, this raised questions about the benefit of this drug. And then on October 25th, 2011, Eli Lilly voluntarily withdrew Xigris from the market after it failed to confirm those survival benefits that were demonstrated in that first trial. So that was a bit of a tangent, but all just to say that the diagnosis and treatment of sepsis under Sepsis 2 and the subsequent Surviving Sepsis campaign basically had a lot of problems, and it had a lot of controversies. Right, so pretty quickly after Sepsis 2, people realized that this wasn't cutting it. Right, we needed to return to the idea that sepsis is first of all, severe versus regular sepsis, that was just dumb, right? All sepsis should be severe. Sepsis by its nature is a severe infection, right? So to delineate sepsis versus severe sepsis, that shouldn't be a thing. All sepsis is severe. right? So we have to revisit these definitions. We have to realize that SIRS is just not good. And then including SIRS plus a menu of a la carte menu of organ dysfunction scoring labs was just confusing everyone, and no one was actually really using it, right? So somehow it took us about 15 years before another conference was put together. All right, why did this stick around for 15 years until we did Sepsis 3 conference in 2016? Well, we can go over that, why Sepsis 2, despite these shortcomings, kind of stuck around so long. So first of all, the science wasn't ready yet. So we were waiting for a lot of new trials at the time and basic science studies to come out for us to better understand sepsis, right? And we're going to talk about some of those trials, specifically the EGT Rivers trilogy, in a couple seconds. Okay, of course, there was also a lack of universal implementation of EMRs in many hospitals, especially in the early and late 2000s. So this made research just a lot slower. You can ask any of your more seasoned attendings what it was like to do like manual kind of chart review with paper charts. It was insane, right? So this just made research a lot slower, not having the EMRs. And once the EMRs started rolling out, especially in the early 2010s, and being kind of really widely adopted, Sepsis 2 really, at that point, had embedded itself into hospital protocols, into academic literature, CMS quality measures, screening protocols within the hospitals, and most importantly, billing. Right? And once something becomes embedded into billing and quality measures, it's going to become really hard to change. Right? Not to mention the 2001 study, the Emmanuel Rivers study, right? We discussed this, supporting end goal directed therapy, EGDT, all right, supported, and it essentially used the Sepsis 2 criteria, and they showed that profound mortality reduction of 16%, with a number needed to treat of just 6 patients in order to achieve that kind of impressive outcome, right? And it became the backbone of the Surviving Sepsis campaign. So all of these things basically made it like politically untouchable, right? Because if you have a study that shows that degree of benefit, it's something that you're going to want to use, right? And it was basically untouchable until 2015 when 3 large multi-center trials, these were the PROMISE trials, the ARISE trials, and the PROCESS trials. And they collectively called these the EGDT trilogy, the End Goal Directed Therapy trilogy. And what they did was they assessed EGDT versus modern or usual care, and they found that there was actually no mortality benefit for EGDT. So they could not replicate that initial 16% reduction in mortality that the first Emmanuel Rivers study showed. And the reason for this was multifactorial. So first of all, usual care had improved dramatically since 2001, right? People just became better at getting antibiotics in faster, getting fluids in earlier, recognizing sepsis earlier. So people just became better at that. Central venous oxygen monitoring, central venous pressure targets, transfusion triggers, and dobutamine, they found that these did not routinely help, and that's sometimes called harm. Right? They found that mortality in both arms had actually fallen compared to prior, right? So doing these things like earlier antibiotics, earlier fluids, earlier recognition was found to decrease the mortality of sepsis in both arms, whether you were doing pure EGDT or just regular routine care at the hospital, right? They also monitored lactate. This was a good thing. And, all of these good things, the early recognition, early antibiotics, early fluids, monitoring lactate, all of these survived EGDT, even though the other things that we don't do anymore, the specific transfusion targets that they use, dobutamine, dopamine, central venous pressure monitoring, these did not survive, right? So going through the timeline, kind of leading up to the Sepsis 3 recommendations that were coming out in basically around 2016, right? So between Sepsis 2 and Sepsis 3, we had 15 years of basically people fighting. So intensivists disagreeing with surgeons, and I mean, this seems like drama, right? Infectious disease versus, emergency medicine, basic science researchers. There was a lot of disagreement, and whenever kind of one person tried to propose something, they ran into resistance from a different specialty. For instance, emergency medicine, their field tended to favor an early detection, kind of SIRS-like kind of definition for sepsis, Whereas the critical care perspective, the intensivists wanted a more mortality predictive definition. The ID physicians wanted more microbiologic kind of support within the definition. And, there was just no consensus for many years. So that's one of the reasons why Sepsis 2 stayed in place for so long, just by default, because there was nothing else. So when Sepsis 3 rolled around, remember Sepsis 2, we had almost 30 people kind of on that panel. And they were from multiple different disciplines, whereas Sepsis 3 was designed by only 19 experts, and they were all critical care. And then only 2 societies participated. So last time we had like 5. This time there were only 2. The SCCCM, the Society of Critical Care Medicine, and the European Society of Intensive Care Medicine. Those are the only 2 societies that participated this time. Everyone else from last time was missing. Right? And it's unclear to me, actually. Feel free to comment if you know the answer, but it's unclear if they didn't want to show up or if they just weren't invited. I'm actually not sure why exactly they weren't part of this discussion. But what was different about Sepsis 3 was Sepsis 3, that conference, and coming up with the definition, it was data-driven. It was data-driven, so they used data from about 1 million electronic health record data sets. And they based it off of the SOFA criteria, the sequential organ function assessment criteria, instead of being just consensus driven, right? And then at this time in Sepsis 3, they removed SIRS completely, which a lot of people disagreed with. Okay, and they changed the definition of sepsis. They said we want it to rely more on organ dysfunction. Right? Of course, the caveat to this is that you would recognize sepsis a little bit later, whereas SIRS, something like tachycardia, fever might be a more early sign of sepsis, whereas waiting for them to have an AKI or liver dysfunction or hypotension or altered mental status, these would all be more later manifestations of sepsis that you would recognize a little bit down the road, right? But in that way, it would be a little bit more specific and mortality predictive. So that was the benefit. It was mortality-based instead of treatment-based, right? And that's what the intensivists at the time who were making this definition really wanted to favor. And that brings us to our new and latest definition of sepsis. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection, with organ dysfunction defined as a change in the SOFA score greater than 2 from baseline. With the SOFA criteria being, so first of all, like pulmonary respiration, PaO2 to FiO2 ratios, coagulation, or, you can look at the platelet count for this. So based on the platelet count, with thrombocytopenia being worse, liver function, right? So if you see an increased bilirubin, that increasing your SOFA score. So cardiovascular criteria like hypotension, right? So if you have hypotension and increased vasopressor requirement, that's going to increase your SOFA score. Neurologic, so your Glasgow Coma score, right? Lower score, meaning increased basically SOFA score. And then renal or kidney. So, you look at the creatinine or the urine output, right? Elevated creatinine being worse and decreased urine output being worse, right? Not to mention they changed the septic shock definition to include, not only, so septic shock previously meant sepsis plus hypotension that was refractory to fluids. They changed it to also include a lactate, right? So in order to diagnose septic shock, in theory, you have to have not only sepsis, but an elevated lactate, I think greater than around 2, and then also the hypotension refractory to fluids, and of course, meaning a requirement of pressors, right? And interestingly, this is our most recent definition, still from the 2016 Consensus Conference. But we do get updates from the SCCM and the ESICM, who are still putting out surviving sepsis campaign recommendations, with the most significant recent update being in 2021, with some more updates, smaller updates that were coming out in 2025. So that just about wraps up our sepsis story and brings us to today. So we have learned that sepsis is a life-threatening disease process that benefits from early recognition and intervention. We have ancient physicians such as Galen, who thought of sepsis as invisible creatures or a miasma, putrid fumes that caused internal decay. And in the 1800s, Sir William Osler recognized that in sepsis, the patient appears to die rather from the body's response to the infection, the severe inflammation, rather than the infection itself. And that in 1914, we have doctors like Dr. Hugo Schott-Muller, who recognized that sepsis was a syndrome that developed from pathogenic bacteria leading to a certain presentation of symptoms, right? So in some ways, these guys were really ahead of their time. And then there was a period of advancement where, we come to the 70s, 80s, 90s. There was a lot of excitement about, the different inflammatory pathways that we were figuring out that basically led to and propagated sepsis with all these different cytokines. And then we tried to come up with more formal and stringent kind of inclusion criteria to define sepsis, like SIRS. And then we found that it really didn't work well. And now it's interesting. I've noted that we have reverted back to kind of a more vague definition, right? Life-threatening organ dysfunction caused by a dysregulated host response to infection. Kind of a more vague definition than that previous boxy SIRS kind of definition. And this really aligns with the heterogeneous nature and presentation of the sepsis syndrome, right? I believe it's important to recognize that sepsis is a clinical diagnosis, as the microorganisms and inflammatory cells that drive sepsis don't really care about human constructs like clinical trial inclusion criteria or diagnosis codes, nor do they care about your heart rate, respiratory rate, or any specific lab value. Sometimes, especially with sepsis, the best thing to do is evaluate the patient at the bedside and use our most important skills, the HPI, the patient history. Listen to what they have to say and what brought them to the hospital. And of course, our physical exam. And I think these are the two most important things that will help us achieve our diagnosis. Thank you so much for listening. This was PM Rounds with Chris. I hope you enjoyed our story of sepsis today. Don't forget to like, comment, subscribe, and share your opinions down below. I'd love to hear your guys' perspective. Thanks for watching, and I'll see you guys next time.